Hello, and welcome to this Red Talk on the exciting topic of circulating tumor DNA in lymphomas. My name is David Kurtz, and I am an assistant professor at Stanford University in California, and will be serving as one of the moderators for today's session.
Thank you, David. I am Marie-Hélène Delfaux-Larue. I am head of the Department of Hematology and Immunobiology in Henri Mondor Hospital, and my scientific and hospital activity is focused on lymphomas, and either on T-cell repertoire for T-cell lymphoma, but also for minimal residual disease in B-cell lymphoma. So, of course, at the beginning, it was for follicular and mantle cell lymphoma, but more recently in the LBCL and Hodgkin lymphomas, thanks to cell-free DNA analysis. And in the framework of the Kalim Institute, I lead the group for the development and harmonization of cell-free analysis in France. So it is my pleasure to introduce Davide Rossi, who, with my co-chair, is an expert in the field of cell-free DNA analysis in lymphoma. Dr. Rossi's clinical and biological activity is focused on lymphoproliferative diseases. He has been and is still a leader in the molecular characterization of CLL and marginal zone lymphomas, as well as identification of prognostic parameters. But today, he's here to tell us about another facet of his expertise, his work on circulating tumor DNA, which he has studied extensively in diffuse large B-cell lymphoma and Hodgkin disease, with 2 high-impact publications in Blood in 2017 and 18. So, Davide, we are listening to you.
Thank you very much, Marie-Hélène, and thank you very much, David, for giving me the opportunity of sharing with you just the data that we are collecting on cell-free DNA. Just confirm that you can see my screen.
Not for now.
Okay. Maybe now you can see.
Yes, fine.
Yes.
Okay, perfect. I will go through the topic of cell-free DNA, circulating tumor DNA, more in general liquid biopsy in aggressive lymphomas. And towards this aim, I will rely on the data that have been generated by the group of David and Asha Lizaday in Stanford, and also the data that have been generated at the NCI by Wyndham Wilson and Mark Roczewski, and on the data that we are generating in our lab here in Bellinzona. I will start with a few words on the terminology and general concepts on circulating or cell-free DNA. All we have cell-free DNA in physiological conditions. Cell-free DNA are a short stretch of double-strand or even single-strand DNA that circulate as a solute, like for example glucose, in the plasma. In healthy individuals, the vast majority of cell-free DNA molecules derive from the lymphohematopoietic system. And these have implication at the analytical level that we will say later in the presentation, and we can further discuss during the Q&A session. In cancer patients, a proportion of cell-free DNA derives from the tumor, because the reason why the tumor releases cell-free DNA is largely unknown. I mean, the biological mechanisms that stay behind this process. The main concept and the main hypothesis that during apoptosis, related to the quick turnover of the cancer cells, these fragments are released from the cells into the microenvironment and then into the bloodstream. We can nominate the the fragments of cell-free DNA circulated in plasma as tumor-derived versus the fragments that are non-tumor derived and are physiological and coming from the lymphohematopoietic system. Here in the cartoon in green, the non-tumoral fragments, and color-coded the tumoral fragments, according to some fingerprints that are typical of the tumors. Generally in cancer, fingerprints that are hallmark of the tumor are the mutations at the DNA level. So if a stretch of cell-free DNA harbor a mutation that is cancer-specific, it can be nominated as a tumor-derived. But in lymphomas, we have other markers of tumor origin of cell-free DNA, which is the tumor-specific immunoglobulin or TCR rearrangement. Later on, I will discuss another aspect that may help in nominating fragments as tumor-derived, despite they don't harbor tumor-specific hallmarks like mutations or rearrangements of the immunoglobulin or TCR receptors, which is the fragmentation sites of the cell-free DNA. Which is the advantage and the value of assessing, measuring, and qualifying cell-free DNA in lymphoma patients? The value is mainly in those lymphomas that are non-leukemic. Liquid biopsy has been used for decades to characterize the biology and genetics of leukemias and leukemic lymphomas, because tumor cells and their genome is circulating in the blood. But in other lymphoma types, for example, aggressive lymphomas as diffuse large B-cell lymphoma or Hodgkin lymphoma, the tumor has does not invade the blood compartments, and therefore the cells, the tumor cells, the lymphoma cells that circulate in the blood compartment are very scant, and therefore you cannot use the blood as in leukemias to characterize the biology and the genetic of the tumor. In this graph that has been published some years ago by David in Blood, you can see the relative or comparative proportion of tumor-derived DNA fragments in the cellular part of the blood versus the tumor-derived DNA fragments in the plasma fraction of the blood. And as you can appreciate here, there is a 2 to 3 log 10-fold higher representation of the tumor DNA in the plasma compartment compared to the cellular part compartment of the blood in diffuse large B-cell lymphoma. So cell-free DNA and derived from plasma is more abundant of as more representation of tumor-derived DNA than the cellular part, and therefore it's an optimal source of lymphoma DNA for genotyping purposes. The investigation of circulating tumor DNA and their potential application in the clinic have been first investigated in the setting of diffuse large B-cell lymphoma, for which we know pretty well the genetic landscape. The tumor biopsy is easy to be genotyped because it's plenty of tumor cells, and therefore we have hundreds of genomes, exomes available in the databases, and the landscape of mutation is pretty well established. I will show you here results from our study, but what I'm showing here is superimposable to the observation by David and Ash in Stanford. If you use cell-free DNA to genotype diffuse large B-cell lymphoma, you will result into a very high concordance of the genotype that you disclose and profile in the cell-free DNA compared to what you profile in the tumor biopsy. But in addition, you can identify in the cell-free DNA some genetic lesions that are not represented in a tumor biopsy. And this has been, this is a common phenomenon observed throughout many cancer types. So the cell-free DNA, the plasma, recruits the tumor DNA from every compartment or anatomical compartment affected by the tumor, and therefore is less biased by compared to the tissue biopsy with respect of the anatomical compartment you are investigating. Because with the tissue biopsy, you are targeting the genotype to the lesion that is undergone to the biopsy, but the tumor may locate in another lymph nodes, for example, in a lymphoma, and the clonal evolution in other lymph nodes may have produced other mutations that are not represented in the biopsy that you have targeted for the diagnostic purposes. And therefore, the cell-free DNA is considered to be a way to characterize in a more consistent way the overall genomic landscape of the tumor, irrespective of its anatomical heterogeneity. What about Hodgkin lymphoma? Hodgkin lymphoma has several limitations, poses limitations in the genotype related to the scarcity of tumor cells within the biopsy. Here you can see an immunohistochemistry stain for CD30 of a typical tissue biopsy of a Hodgkin lymphoma, classic Hodgkin lymphoma lesion. And in brown are stained the cells that are the Hodgkin stem cells, the tumoral cells, which are very scant and few, and surrounded by a lot of non-tumoral inflammatory cells. The typical amount of Hodgkin lymphoma tumor cells in a Hodgkin lymphoma biopsy is in between 1 to 5%. So a tumor representation that is very low, if you perform bulk in order to get reliable genotypes, if you perform bulk exome genome sequencing without enrichment of the Hodgkin stem cells. Therefore, if you would like to genotype Hodgkin stem cells from the biopsy, you have to enrich by laser microdissection or flow cytometry. And such technicalities imposed a major barrier in broadening the genotyping of Hodgkin lymphoma through genome exome sequencing as much as it has been done for diffuse large B-cell lymphoma. And indeed, if I recall correctly, in the literature and in the databases, you can retrieve not less than 100 genomes or exomes of classic Hodgkin lymphoma, Hodgkin stem cells. Here, the liquid biopsy can provide a tool because we have shown that the genomic landscape that you can retrieve by genotyping the circulating DNA in plasma is highly superimposable to the genetic landscape that you can retrieve by genotyping Hodgkin stem cells. And therefore, you can use the liquid biopsy as a tool for deriving the genotype, if in research setting, of course, of classic Hodgkin lymphoma, that may overcome and bypass the hardness that are in the technicalities needed for enriching Hodgkin stem cells from the tissue biopsy. So to summarize this first part of the presentation, we can say that virtually all cases of lymphoma have measurable levels of circulating tumor DNA in the peripheral blood. So the plasma is a good source of lymphoma DNA for genotyping purposes. The genotypic profiles of the lymphoma in circulating tumor DNA strongly correlates with the profile that you can identify in the paired tumor tissue biopsy. So circulating tumor DNA is highly reliable in providing the genetic landscape of the lymphoma. But it may add something more because you can find unique mutations in circulating tumor DNA that are not identified in the tissue biopsy because of the anatomical heterogeneity that I mentioned before. And these final aspects has potential implications if you are going to target or using mutation as biomarker for treatment tailoring, because in some very heterogeneous lymphomas, like for example follicular lymphoma, some therapy driving mutation may be hidden in the lymph node that is not subjected to the diagnostic biopsy. Let's go now to the technologies that you can use for quantifying and qualifying circulating tumor DNA. A step back. In the plasma, in 1 ml of plasma, usually you can find around 2,000 genomes, highly fragmented, of course, of cells, which may contain bracket genomes of the tumor and bracket genomes of normal cells. As I said before, to nominate those genomes or fragments that derive from the tumor, you need mutations or immunoglobulin G rearrangements. And if you quantify them into the cell-free DNA, they are very rare. The red dots here are the tumor originating cell-free DNA molecules. All the rest are coming from normal tissues. And another background concept is that apart from lymphoplasmacytic lymphoma, which has a unifying genetic lesion, the MYD88 mutation, all the rest of lymphomas have no unifying genetic lesion. So in order to discriminate cell-free DNA fragments, whether it comes from normal cells or tumor cells, you need to rely on a landscape of mutation and not just one. Which are the implications of this concept? First, if you use PCR-based technologies that usually target one single mutation, although they are very sensitive, they can be applied only to, if you would like to be comprehensive, only to one specific type of lymphoma, lymphoplasmacytic lymphoma, the MYD88 mutation, or only to a subset of lymphoma patients if you are targeting a mutation that is quite recurrent in a lymphoma type, although it does not recapitulate all cases. In order to have a technology that can be broadly applied to all lymphomas, irrespective of the histology, you need to shift to sequencing technologies, which might target the immunoglobulin genes. In this way, you can quantify the tumor load in the plasma and follow the tumor load under treatment. But of course, if you target the immunoglobulin genes, you cannot identify the mutational landscape, including eventual prognostic or predictive mutations. Or instead, you can move to targeted sequencing approaches, which are designed to sequence and enrich for regions of the genome that are highly mutated in lymphomas, like, for example, the Capsid technology. This allows not only to identify and quantify the levels of circulating tumor DNA even at any given time point of the course of the disease, but on top of this, and at variance with the immunoglobulin gene sequencing, it also allows to characterize and qualify the mutational landscape, including the identification of prognostic and predictive mutations. Which are the technicalities and the critical aspects in circulating tumor DNA quantification and qualification? As I said before, the ctDNA is of low abundance in the plasma, and therefore you have to optimize the sensitivity and specificity of your approach, next generation sequencing and bioinformatic approach, in order to be very accurate. Here on the right side of the slide, you can see the allele frequency of a number of mutations measured in genomic DNA from tumor-sorted lymphoma cells. Sorted lymphoma cells. So you have the clonal mutations, 100% of allele frequency, hemizygous mutations, 50% of allele frequency, subclonal mutation, less than 50% of allele frequency. So as you can see, most of the mutations are in the range of 10 to 100%, or between 1% to 100%, a range of allele frequency that can, with the current technologies being pretty well and confidently detected also in the diagnostic lab. On the left side, you can see instead the allele frequency of a number of mutations identifying the cell-free DNA. At variance with the genomic DNA, very few mutations are in the range of allele frequency between 10 to 100%. Many mutations are in between 1 to 10%, and there are mutations that are even below the 1% threshold. And in this part of the allele frequency, you fall in this gray zone, the gray zone where you have to distinguish the true variance from the background noise that is introduced in the sequencing by the PCR errors and other stereotyped mistake of the process. And in order to optimize the call of true variance versus the false positive variance, the errors, you have to suppress the background noise of the sequencing. And you can do it both at the biochemical level, the wet level part of the sequencing, as well as at the post-analytical level, the bioinformatics level. The biochemical level is correction is the inclusion in the library preparation of the barcoding. The bioinformatic level is a pipeline that allows to nominate the background noise, the stereotype errors of the background noise, and subtract them in silico in order to suppress them. And with either one of the two approaches, the linearity of the analytical sensitivity stops around in between 10 to the minus 2 and 10 to the minus 3. With both, you can go down to 10 to the minus 3. There are other ways, still on the technical part, that you have to take into account in order to improve the sensitivity of your approach. First, on the right side, you can see that the more genomic equivalence, so the more amount of cell-free DNA you input into the library preparation, the higher the sensitivity of your approach. That's easy to understand if you input more DNA fragments, you are more sensitive in detecting the few ones that have mutations. But also the number of mutations is important, because if you target just one mutation in your NGS approach, you have a lower chance of detecting it if it is scant in the fragments of cell-free DNA, compared to whether you target more than one mutation, 4, 8, 10, 20. The more mutation you have, the more is the chance that even if you load not very high amounts of cell-free DNA, you can detect the ones that are of tumor origin. So the best approach is inputting a good amount of DNA, more than 30 nanograms, and targeting and using an approach that have the highest chance of targeting a high number of mutations that are lymphoma specific. One aspect that is pre-analytical and is critical, especially, and the clinician should be aware and educated on this, especially if they deal with cell-free DNA in the design of clinical trials, is the preservation of the blood once it is collected from the patient. The preservation is critical, and the preservation of the blood needs special tubes. Here in the top part of the slide, you can see cell-free, a plasma sample which has been well preserved. And as you can see, you have the spike here of the cell-free DNA with no other spikes. Below you can see a plasma samples of poor quality, not well preserved. You still have the spike of the cell-free DNA, but you have other spikes. These other spikes are fragments of genomic DNA that are released in the tube by the leukocytes that are dying in the tubes while awaiting the tube to be processed. In order to mitigate and the consequence of this contamination of the cell-free DNA by the genomic DNA of the leukocytes is that the cell-free DNA will be further diluted, and therefore the tumor DNA even further diluted, and therefore the sensitivity of your approach in detecting circulating tumor DNA may be impaired. In order to prevent this, as I said before, you have to use those special tubes that allows to stabilize the leukocytes in order to impede them to release their own genomic DNA while the tube is traveling, for example, from the study site to the central lab where the cell-free DNA assay will be done. Step back to the concept of the physiological origin of the cell-free DNA in healthy subjects. The cell-free DNA derives from the lymphohematopoietic system. We know that even normal subjects may harbor mutations in the lymphohematopoietic system that they nominate and define the clonal hematopoiesis. For example, TET2 mutations, SXL1 mutations, DMT3A mutations are pretty common especially in older subjects, and this occurs, of course, also in cancer and lymphoma patients. The mutations, the fragments of cell-free DNA harboring mutation derives from the clonal hematopoiesis are, of course, diluted within the plasma along with the cell-free DNA fragments derived from the tumor you would like to investigate. And assigning a DMT3A mutation, which is derived from the clonal hematopoiesis, to a lymphoma that you would like to investigate is, of course, a mistake. In order to avoid this, you should genotype along with the cell-free DNA, also the genomic DNA collected at the same time, derived from the leukocytes circulating in blood. In this way, you can nominate the mutations of the clonal hematopoiesis in the leukocytes and subtract them from the counting of the mutations that you identify in the cell-free DNA in order to polish and to censor the clonal hematopoiesis from the final viral calling that you would like to ascribe to the tumor you are investigating, in this case, lymphoma. To summarize this second part, at the pre-analytical level, it's of critical importance using cell-stabilizing tubes where to collect bloods in order to minimize the effect of white blood cell lysis and contamination by this from this of the pure circulating cell-free DNA. Analysis of paired germline DNA, as I said before, allows to suppress the signal from clonal hematopoiesis and therefore misunderstanding mutations of clonal hematopoiesis origin as a mutation of tumor origin. There are, however, several aspects that still have to be addressed and still matter of research and validation in the technical field of cell-free DNA analysis, which are two of these are mentioned here. We don't know which is the best gene panel to be used for lymphoma genotyping on the liquid biopsy. We don't know which is the best method of next generation sequencing and library preparation and bioinformatics in order to detect these aberrations. And therefore, here is needed an harmonization, a standardization and harmonization approach, especially if you would like to transfer this technology in the clinic, like the one that has been done in the setting of minimal residual disease assessment by flow cytometry or by molecular methods in the field of CLL, for example, or other lymphoma types. Let's go now to the clinical part of the presentation, which are the advantages of clinical research part, which are the potential benefits of using the liquid biopsy, the cell-free DNA, in lymphoma research and eventually in the clinics. Well, we have to commend Ash and David for having developed this technology, the CAPSIC, which is capture-based next-generation sequencing approach that allows to target a region of the genome that is enriched of mutation in lymphomas, and by this way allows on the cell-free DNA to identify clinically relevant mutations. This is pretty well established in diffuse large B-cell lymphoma, but also is consolidating the setting of Hodgkin lymphoma. But beside qualifying, so nominating the mutations, this approach can also quantify the load of tumor DNA in the plasma, and this is the load of circulating tumor DNA is a very precise matrix of the total tumor load of the lymphoma, because it correlates with the stage of the lymphoma patients, which is a raw way of quantifying the tumor load, but it highly correlates also with the total metabolic tumor volume, which is a more precise way of measuring the tumor load based on a radiomic tools the radiomic features and metrics derived from the PET scan. During the course of the disease, measuring the residual levels of circulating tumor DNA is prognostic, especially, of course, at the end of therapy. I think that at that time point, the discrimination capacity between cure versus not cure is very high, as it is high for PET scan. But also, as for PET scan, the discrimination capacity of measuring or not measuring circulating tumor DNA is also high at the interim time point. And this is validated in independent cohorts by independent technologies, the CAP-seq in the LBCL, sorry, the CAP-seq technology, and the Stanford group provided this evidence, or by sequencing the immunoglobulin gene rearrangements in the blood by the clonal-seq approach. What we have done in this field, well, we have established our variant of the CAP-seq assay by designing, first of all, a target region that includes a number of genes that are recurrently mutated in mature B-cell tumors, as well as non-coding mutations that are affected by the aberrant somatic hypermutation process. And I will come later on this specific aspect and the eventual importance. The library preparation protocol is essentially the CAP-seq. The bioinformatics is essentially similar to what is done in Stanford. We rely on an error suppression technology, which allows a 10 to the minus 3 sensitivity. And we validated this approach at the analytical level and the clinical level. At the analytical level, you can see here that our target region is almost at the top of the chance of recovering lymphoma mutations compared to what you would recover if you use a broad exome sequencing, which is doable in cell-free DNA, but with some constraints that we can discuss during the Q&A session. This for coding mutations, and it can recover almost all the aberrant somatic hypermutations. Our approach can detect in a experimental way confirmed the mutations that are tumor biopsy confirmed. More than 99% of mutation can be detected. Have a limit of quantification of 10 to the minus 3 and analytical sensitivity again of 10 to the minus 3. And we clinically validated this assay or this technology, a variant of the CAP-seq technology, in a clinical trial samples from the LYM 1002 trial, which used ibrutinib plus nivolumab in the setting of relapsed B-cell lymphomas, including follicular, diffuse large B-cell, and Richter syndrome. The landscape of mutation that we profile in plasma samples collected at during the screening before treatment start is a very complex slide, but just to underscore that for each histology, we were able to recover those mutations that in terms of type and frequency that are characteristic for the tumor type. In terms of prognostication, all we know that p53 abnormalities in CLL/Richter, the LBCL and follicular lymphoma are prognostically relevant, and the same was confirmed with our assay based on cell-free DNA. Only p53 mutations were prognostic in this setting, with the split of the curve that is pretty nice in terms of PFS. And during or longitudinally under treatment in the setting of in the subset of DLBCL that were treated in this trial, we were able to discriminate those who become after 2 courses of nivolumab plus ibrutinib 2 cycles, molecular negative, approximately 1/3 of the patients from those who remain molecular positive in the plasma. Molecular negativity correlates with having CR or PR as best response during therapy, and of course with the outcome, as you can see here. And we also validate this approach as a way to recover the clonal evolution. And in this triangle plot, this is the important axis to focus on. The mutations that are acquired under, during, or the end of therapy are mostly the ones that you would expect in an ibrutinib treated setting like BCL gamma 2 mutations. So to summarize this part, baseline ctDNA levels are prognostic and correlate with measures of tumor burden like PET scan measures. Levels of ctDNA change rapidly after treatment. So this may be used as a tool for early detecting sensitivity of resistance of the tumor. The dynamics of the decrease of circulating tumor DNA under treatment correlates with outcome, and you can detect clonal evolution by monitoring the genotype of the lymphoma by using circulating tumor DNA. This is a very important paper published by David on last year, who established this technology, the phase-seq approach. The phase-seq approach relies on the phase variant. What are the phase variants? Are variants that occur in CHIS 2 or more on the same stretch of cell-free DNA. And if you have this pattern, 2 or more variants on the same stretch of cell-free DNA, you can almost 100% be sure that that cell-free DNA is of tumor origin. This is not an error of the sequencing. Conversely, if you have just one variant on the stretch of cell-free DNA, this might be an error or a true mutation. So if you count and if you relay your circulating tumor DNA detection of the phase variants, you can improve, and you can see here the linearity of the assay, the sensitivity of your approach below the 10 to the minus 3 sensitivity of the CAP-seq, and you can go down to 10 to the minus 4, 10 to the minus 5 either. Phase variants are specifically, or not specifically, but very, very common in B-cell lymphomas because they are produced by the aberrant somatic hypermutations. The aberrant somatic hypermutation produce or introduce in small regions of the DNA coding or non-coding a high amount of variants, which therefore may be represented in a stretch of cell-free DNA, which is usually short, 167 base pair. And therefore, phase variants are an ideal tool to quantify circulating tumor DNA in lymphoma patients. I would like to move now to more recent data and come back to how we incorporated the phase variant detection in our research in the cell-free DNA of in the liquid biopsy, in the field of liquid biopsy of lymphomas. We have this ongoing observational study, which is collecting plasma samples and PET scans longitudinally across different histology of lymphomas. And now we are addressing classic Hodgkin lymphoma we recruited 135 patients with a median follow-up of this cohort of 4 years, and we applied a sort of phase variant enhanced CAP-seq approach to quantify and quantify circulating tumor DNA in Hodgkin lymphoma and address some clinical questions. The first clinical question, this is the primary endpoint of the study, is whether the integration of interim PET scan plus interim molecular response on the liquid biopsy is more accurate than the sole interim PET scan in anticipating the outcome of classic Hodgkin lymphoma. And the background is here. While this is the summary of a meta-analysis of a few years ago, which addressed the question on which is the false positive rate of the interim PET scan. In non-Hodgkin lymphoma, there are 4 studies, and the meta-analysis defined that the false positive rate is 83%. False positive rate means a positive PET scan that is confirmed by a biopsy directed to the interim PET positive lesion. While instead we have no data in the setting of Hodgkin lymphoma, no studies has been done addressing whether with a biopsy at the interim time point of a positive lesion at the PET scan is a residual disease or whether it's an inflammatory scar. And the second background notion is that if we rely on progression-free survival as a way to define whether the interim PET scan was still residual disease, and if we look at the data of modern data in a setting where the treatment was not changed according to the interim PET scan result, there are a few studies, and one is the LISA trial, which in the comparative arm, patients with the interim positive PET were treated with PCOP and not de-escalated. And in this setting, the progression-free survival is 72%, which means that despite a positive interim PET, while continuing the same therapy, 72% of patients can be cured. So having said that, and a final background notion, we in a pivotal and proof of principle study, we showed that among patients with a positive PET scan at the interim time point, the liquid biopsy showed a negative result, so lack of residual disease, which means that eventually the liquid biopsy can confirm or not confirm whether the residual positive lesion is lymphoma or inflammation. And in this cohort of our prospective study, we centrally revised the PET scan, and the Deauville score was assigned by a panel of reviewers, nuclear medicine physician who reviewed the images, and the molecular response was defined by our CAP-seq approach that incorporated both also the phase-seq of the phase variant counting. And as you can see, only the double positive patients, so the patients having an interim PET positive disease, which means a Deauville score of 4 or 5, along with the positive molecular residual disease, were the one having a higher risk of progression compared to the patients having both negative approaches or one or the other, either positive PET only or MRD only. The next question that we are investigating is whether pretreatment ctDNA load is a prognostic biomarker in Hodgkin lymphoma. we don't have at baseline solid prognostic biomarkers. The IPS is not so discriminative, as you can see here in the RedTalks trial. It might be more discriminative, the metabolic tumor volume, although the data are laying only in the setting of limited stage Hodgkin lymphoma. We showed that the qualification of cell-free DNA or ctDNA is not prognostic. There are no mutations that are associated with outcome in classic Hodgkin lymphoma, but instead the quantity of cell-free or circulating tumor DNA at baseline is highly prognostic. And you can see here that among patients having high ctDNA load with this threshold that we are now validating in an independent cohort, have a progression-free survival of only 40% compared to patients who have a low ctDNA load at baseline. And the final question we are addressing whether we can define biological subgroups of Hodgkin lymphoma. Hodgkin lymphoma is a heterogeneous disease, pathologically, from the infection standpoints, EBV positive, EBV negative, clinically, genetically. So as in diffuse large B-cell lymphoma, likely subgroups exist defined by mutations or by other features. However, we have not yet, we don't have so far the statistical power to subgroup based on genetic or molecular aspects of Hodgkin lymphoma because we don't have large cohorts genotyped as we have in diffuse B-cell lymphoma. But as I said before, by using the liquid biopsy, we can derive the genetic landscape of Hodgkin lymphoma, so increase the number of patient genotyped and therefore have the statistical power to try to dissect molecular subgroups. Another background notion is that beside mutations, you can profile the fragment size of the cell-free DNA, and which is the utility of measuring the fragment size. The fragmentation of the cell-free DNA is dictated by the position of the nucleosomes in the region that you are investigating, because the enzymes that cut the DNA, which is then released into the plasma, as I said, cuts around the nucleosomes. So if the chromatin is closed, the cuts are made beside the nucleosome in a stereotype fashion. So the typical nucleosome wrap of DNA is length is 177 base pair. If the cut is made beside two nucleosomes, it is the double. And this is the typical shape that you have in normal subjects. In the regions where the chromatin is open, the cuts are made more randomly, and therefore you have even shorter fragments that you can profile here. Therefore, the fragmentation of the cell-free DNA reflects somehow the status of the chromatin. Whether it is closed, you will have stereotyped fragments of the length of one nucleosome or two nucleosomes, or open chromatin where you have fragments in the cell-free DNA which are shorter than a nucleosome length, so they are termed subnucleosomals. And we use this approach to dissect the heterogeneity in Hodgkin lymphoma, and we identified four different groups of patients. A group of patients having dinucleosomal fragmentation, similar to the one that you have in healthy donor, the blue dots, while the red dots are patients. Sorry, this is the graph, identical to the normal subjects. Then you have some patients having a dinucleosomal fragmentation, so less mononucleosomal and more dinucleosomal fragments. And on the left side, you have patients having subnucleosomal fragmentation, less pronounced, so small fragments here, more than in the normal counterpart, or more subnucleosomal fragments. And this subgrouping of Hodgkin lymphoma patient has clinical and genetic implications, because at the clinical level, the subnucleosomal subgroups, which are here highlighted in the dark and light blue, the ones having, let's say, more open chromatin in the tumor, are oldest, have more B symptoms, have more elevated ESR, higher stage, and higher IPS, which is the scoring prognostic score of Hodgkin lymphoma, and worse progression-free survival. But they also have more mutations, as you can see here. If we group the patients according to the mutation status in an unsupervised way, we can divide Hodgkin lymphoma, classic Hodgkin lymphoma, into two groups. One having heavy aberrant somatic hypermutation, two or more regions of aberrant somatic hypermutations affected, and one group having light aberrant somatic hypermutation, only one or zero regions of aberrant somatic hypermutation affected, and this correlate with the total tumor load, tumor mutation load with outcome, and the subnucleosomal clusters, so the clusters having larger, more open chromatin, are more frequently characterized by heavy somatic hypermutation signature. To conclude, some perspective how we are translating the ctDNA technologies into clinical trials. Well, we are well recruiting now in the SKK 3819 trial, which is dedicated to diffuse large B-cell lymphoma. And the trial is a first-line treatment trial where the patients are stratified according to the baseline ctDNA qualification. I mean that they are divided on whether they harbor a mutation of sensitivity to BTK inhibition, MYD88 and CD79. In this case, they receive acalabrutinib plus R-CHOP, or whether the patients are devoid of this mutation, they receive standard R-CHOP. And in this group, the second decision node is whether they have combined PET and ctDNA response at the interim time point. If it is yes, they are de-escalated to only 4 total R-CHOP courses. If no, they are escalated by the addition of acalabrutinib. Otherwise, if they have discordant PET and ctDNA results, they proceed with the standard 6 courses of R-CHOP. While in Hodgkin lymphoma, we are collaborating with an European effort in the rafting trial, which is dedicated to early stage Hodgkin lymphoma patients. The question of the trial is whether the treatment can be de-escalated by avoiding radiotherapy in cases having favorable PET features in terms of baseline MTV and response after ABVD. And the liquid biopsy is used here for monitoring and early intercepting the relapse after the treatment stop, and triggering the clinical imaging to confirm the relapse, and eventually then reinstitute therapy with radiotherapy and then consolidation with checkpoint inhibitors. And with that, I have concluded. I have to thank all the people that are working in the lab, in my lab here in Bellinzona. You have a nice shot of them here with the mountains in the background. This is our new institute. We moved here in October. And thanks also to all the funding agencies. And thank you very much for your attention.
Thank you, Davide, for your presentation. I think David will ask some questions from the audience.
Perfect. Yes, and just for the rest of the audience, feel free to ask more questions in the question tab in the lower right-hand corner. We have two questions from Professor Thibault and Professor Nadal, who are kind of in the same vein. I'll ask Professor Thibault's question first. To Davide, congratulations on the presentation. How do you explain the good outcomes for the PET negative ctDNA positive patients in the series? So these are the patients that are not having residual disease by PET scan, but still have residual disease by ctDNA. Did you measure a difference in ctDNA load between PET positive ctDNA positive cases and PET negative ctDNA positive cases?
So that's a good question, and it's something that we are exploring. These are data that we are still collecting and consolidating within this project. If I asked to David to confirm, but I think that the same, the discordant cases, having only PET positive or only liquid biopsy positive are the ones having a good outcome compared to the double positive, also in the setting of diffuse large B-cell lymphoma. So this is something that across diseases seems to be confirmed. I have no biological or clinical explanation for this so far, but maybe, David, you can further comment based on your data.
No, I would agree in the DLBCL experience that we published as well. The double positive patients do universally terribly. The double negative patients do nearly universally well, and patients with one positive, one negative do intermediate. I think the one caveat I would say is that these are all measured during treatment in our experience, and so there is additional therapy afterwards, right? So these are patients who have only received perhaps 1/3 of their treatment. So if you have a low disease burden left, you have 2/3 more of your ABVD in the case of Hodgkin lymphoma, or R-CHOP in the case of DLBCL. So I suppose the end of therapy time point as a true litmus test for positive or negative may be better. And there probably are differences in performance between the different time points, and that needs to be sorted out still.
Yeah, I will also comment more on this. Introducing the discussion one additional clinical aspect or therapeutic aspect that is specific for, or more specific for Hodgkin lymphoma. That unplanned radiotherapy in an advanced stage Hodgkin lymphoma, which is the major part of the patient that you have seen in the curve, is delivered if you have end of treatment PET positive lesions. And this may explain, at least in part, this behavior of the single positive. And we are exploring this by plotting, although I not yet have the data, the event-free survival, which counts as event also the delivery to the patient of unplanned treatment after the pre-planned therapy.
And just to follow up on that a little bit from Bertrand, do you have the data on the performance of ctDNA alone? If you put those curves together for ctDNA positive, is it still prognostic without PET scan in Hodgkin lymphoma?
Yes. Yeah, we can considering still with the caveat of considering progression-free survival, which has this bias in Hodgkin lymphoma that does not take into account having further treatment that was unplanned. The curve divides pretty well. Also, if we just consider molecular response at the interim time point, but also, of course, also interim PET scan, which is a sort of validation of the reliability of the core that we have. I didn't show the data because, as I said, this is a manuscript that we are assembling now, and therefore we have not yet the full data already available. But yes, that's the case.
Can you remind me again which time point you're using for the interim time point in Hodgkin lymphoma?
Well, we aligned per protocol, the liquid biopsy was performed by the nuclear medicine physicians the same day they have done the interim PET scan. So after 2 courses of treatment.
Got it. Yeah, I think that finding the right time point, which we try, I know that both your group and ours have tried to do this as well, I think is a very important question as we clinically translate this, because in our experience, the levels of ctDNA and Hodgkin lymphoma go down very quickly, which was part of the motivation for phase-seq. But I think that as we get more data, understanding what does ctDNA look like after 1 course of ABVD, perhaps even half a course, perhaps 2 weeks into treatment is the right time point. And those types of details, I think, are going to be essential as this is translated.
Yeah, I fully agree with you that the reason why we design is in this way, the prospective study is to try to align to the clinical standard approaches, also the collection of the liquid biopsy, but it might be that moving, as you said, the time point may provide more accurate estimates. And as for the PET scan, it has to be studied until when the best way is fixed.
I have a question for both of you about the tumor load calculation at diagnosis. How do you manage with subclonal variant? Did you discount for the calculation, or do you include them?
Well, David first.
Sure. I will tackle that one first. So we do include subclonal mutations in our calculation, like very kind of nuts and bolts. We genotype typically 100 or a few, maybe 200 mutations with these aberrant somatic hypermutation regions per case in DLBCL and also in Hodgkin and other non-Hodgkin lymphomas. And we simply take the arithmetic mean of those allele fractions, right? That is what we do. So some of those things are confounded both by subclonality as well as confounded by copy number variations, right? So if you have a deletion or an amplification, you may get an individual mutation that goes up or goes down. In our experience, because these things happen on a log scale, generally speaking, whether or not you are including which set of mutations you're measuring tends to make a relatively small difference in the actual quantity of ctDNA, because you're usually comparing things that may be 1 genome equivalent per milliliter to 2,000 genome equivalent per milliliter. And so if you're off by 20 or 30%, it's not such a big deal. Davide, what are your thoughts on that?
Yeah, we are using the same approach, and I would do a step back, because when you are dealing with cell-free DNA, the clonal subclonal concept does not apply, because the mutations are diluted, in a lot of normal cell-free DNA fragments, and therefore it's almost impossible that you have a clonal mutation, fully clonal, 100% of the fragments having, or the cell-free DNA having this mutation. So per definition, all the cell-free DNA mutations are subclonal. So we include in the arithmetic mean calculation all the variants that pass the statistical filters and are considered bona fide of tumor origin.
We have another question from Sandrine Roland. Thanks, Davide, for the clear presentation. A technical question. In your experience, what is the performance for detection of chromosomal rearrangements compared to single nucleotide variants, or I suppose small indels, in ctDNA profiling?
Personally, I don't have experience because we never tackled this in our CAPSEQ, but I think that you, David, can comment on this, because you included the positions of the breakpoints in some of your target regions, and you have the data.
Yeah, so I would, we've done some of this. We've definitely done some of this. So I would say it is better for single nucleotide variants and small insertions and deletions. I think that is pretty clear. For breakpoints, you need to really map the reads to both portions of the genome, which that very technically on the mapping side is challenging, especially from short fragments, which cell-free DNA molecules are like 160, 170 base pairs long. So the probability of having both portions of the molecule is low. And then that's additionally complicated by the diversity of breakpoints, right? So it depends on the translocation. BCL2 is actually a very good one because the BCL2 breakpoint is so stereotyped and overwhelmingly goes along with chromosome 14. So you have two pretty well-defined breakpoints. MYC and BCL6 in the case of diffuse large B-cell lymphoma are more challenging. Although with that being said, we still can recover a majority of them, but is not as good as for SNBs.
Well, from the clinical standpoint, what I can comment is that I think it's much easier to do a FISH on a tissue biopsy, right? Technically speaking, than trying to recover translocation by using liquid biopsy. And also considering that these translocation we are considering, which are diagnostic or prognostic, are fully clonal. There is no reason why looking for them in a liquid biopsy because of the concept of anatomical heterogeneity.
I think there is not so many pathologists with us, but do you think that ctDNA could replace biopsy for the diagnostic of lymphoma?
No, I don't think so. I think that it's a complementary. It's not complementary for the diagnostics because you can derive the genetics, of the tumor if it is diagnostically relevant directly from the biopsy. It might contribute, for example, in clinical trials or in the future in the clinic. If you would like to have a tool for having relatively quicker genotyping, I can tell you the experience that we have in the SKK trial. Our turnaround time for delivering to the center the MYD88 and CD79 mutation status is 10 days, not 10 working days, 10 days, which is shorter, as you can imagine, than time to delivery of the report if the block have to travel from the center to the central lab and then back again. That's for mutation identification. While for clonal evolution, it might be because if you have a lesion that is not accessible and you would like to look for a mutation that is relevant for treatment tailoring, you might use the liquid biopsy. The only situation where I would see the liquid biopsy as a very strong tool to complement the diagnostics is in the primary CNS lymphoma. There was this great presentation by Florian Scherer at ASH. And in that setting where the diagnosis sometimes is challenging, the biopsy might not be reliable because of steroids that have been given before. The biopsy, the lesion is not easily accessible. The radiologist may suspect a glioblastoma, and so instead of a biopsy, the surgeon would like to debulk. So in that setting, having a tool that may improve your confidence of lymphoma, of having a lymphoma as final diagnosis would be very helpful in the clinic. And I'm looking forward very much of having this tool available in the clinic soon for primary CNS lymphoma.
David, another question for David.
Yeah, Professor Thiebelmont was asking about the same thing regarding the CSF, this experience in CSF in primary CNS lymphoma. Have you done any of that profiling yourself? Have you tried that approach in your lab yet?
Well, what we are trying to establish in the diagnostic lab, not in the research lab, is droplet digital PCR assay targeting the MYD88 mutation, which accounts for 60 to 80% of primary CNS lymphoma, which is less technically complex for a diagnostic lab than a CAP-seq approach, but may be useful, although not fully accurate, but with which may improve the accuracy of non-invasive diagnostic along with the imaging of PCNSF, PCNSL, and therefore that's the way we are proceeding in our diagnostic lab. And I think that by the end of this year, we will introduce this in the clinical routine. So, I mean, having the digital PCR for MYD88 on CSF in patients who need differential diagnosis, for which the lymphoma is in the differential diagnosis.
Yes, we already have in routine for droplet PCR, and we have some experience on NGS just using lymphopanel, not CAP-seq. And for some case, in cell-free LCR, we had more mutation than in cell. You mean you give the pellet, you have nothing, but you take the cell-free of LCR, and we have a nice, clearly lymphoma panel pattern. Could be useful, sure.
From the CSF, separating out the cellular material from the CSF. Yeah, I think that Florian's experience was somewhat similar. I think that he ends up sequencing both fractions because DNA material can be so limited in this. But it does seem like the cell-free material in CSF seems to be where there might be more signal. Along those same lines, Davide, thinking about other lymphomas, right? Moving outside of diffuse large B-cell lymphoma and Hodgkin lymphoma into perhaps more difficult diseases. What is your experience in low-grade lymphomas, follicular, marginal zone, LPL, and the like? Where do you think ctDNA will wind up for those?
Well, what I can say, I have experience in CLL and small and SLL. In CLL, so in patients having a leukemic component, there's no much difference if you genotype the plasma-derived DNA versus the self-derived DNA. So you don't capture too much the eventual anatomical heterogeneity, while instead in SLL, the accuracy in recapitulating the tumor genotype comes paradoxically by complementing both the DNA of cellular origin in blood circulating SLL cells and the cell-free DNA. There are literature experience indicating that, of course, you can genotype the MYD88 mutation in lymphoplasmacytic lymphoma. That's I have no large experience in follicular lymphoma, although the cases that we genotype indicate that you can retrieve more mutation in the plasma than what you have by genotyping the tissue biopsy. But I think that this is in line with the great heterogeneity and also anatomical heterogeneity that exists in follicular lymphoma, where you have lesions with different SUV max at the PET scan, different grading if you biopsy more than one, and you also shown in your in your seminal paper on that also the mutation landscape is different across different biopsy sites.
And what about the suspicion of Richter syndrome in CLL? Plasma does not add some information?
I don't think so, because we don't have actually an absolute biomarker, of transformation. So because genetic biomarker, I mean, those p53 mutations are shared between aggressive CLL, progressive CLL, and Richter. The MYC translocation either, although are more specific, but there are the caveats that David has mentioned before. Another lesion that is frequently acquired in Richter, but it's also frequent in aggressive CLL or CDK P14, P15, P16 deletions, but we can open a new chapter here whether cell-free DNA can detect copy number abnormalities. So actually,
Yeah,
I don't think that it might provide diagnostic information over the clinical and PET scan clues or suspicion, or they provide suspicion of. It can. We have experience in CLL on the identification of mutational resistance to ibrutinib. Our working hypothesis was whether the mutations are hidden in the lymph nodes at the beginning and not well represented in the circulating part of the disease, but this was not the case. We have a prospective core in which we genotyped flow sorted CLL cells at different time points under ibrutinib therapy and the cell-free DNA, and the mutation comes out, comes in both the blood compartment at the time of clinical progression, while before they are not detectable in neither compartment. So also in that setting it is not useful.
Yes, one question about T-cell lymphoma. It's a question from Olivier Tournillac, especially TFH. Was that shared mutation with CHIP in the same patient? What did you propose?
Well, I think that here David may address this question because they developed an approach to further sort out, chip mutations over the just the sequencing of paired leukocytes.
Yeah, chip mutations are I will say are quite challenging when they are shared. So generally speaking, we sequence very deeply plasma plus shared PBMCs. One of the interesting things does seem to be that tumor-derived variants, as opposed to hematopoiesis-derived variants, have different ctDNA size profiles. So similar to what Davide was showing in terms of some of the sub-monosomal and subnucleosomal patterns from Hodgkin lymphoma, on average, the DNA fragments that come from a tumor cell of origin are shorter. And so if you have enough tumor fragments, you can make that distinction. We've used that more in solid tumors in our experience, but I think that same thing does seem to apply in lymphomas as well. So that might be something that's worth exploring. The one caveat I suppose I would say is if this is like a shared mutation in a founder, that mutation is present in a clone that goes and becomes all of hematopoiesis and then also becomes a T follicular helper T cell lymphoma, then you'll have a hard time differentiating them because you basically will have this admixture of both fragment lengths. So I think it's challenging. It would be my answer.
No solution.
Yeah, one way that you can use in different settings, if you have any doubts about the origin, is the discrepancy, David, between the representation of the variants. Is it right?
Yeah. I think that's the other place that can be we can think about ctDNA potentially helping pathologists, not replacing pathology specimens, but as we think about, for example, transformed lymphoma from follicular lymphoma into DLBCL, our observation is that the mutations occur out of proportion compared to either prior samples, right? So more heterogeneity or more ctDNA burden, more mutational burden as compared to the amount of PET scan burden. I think we don't have data for this, but the same thing may potentially be true in Richter's as well, where it's happening, you see more ctDNA than you might expect. So the same thing could be true here as well, right? If you have a T follicular helper lymphoma, you may see a discrepancy, right? More of that mutation in the cell-free DNA than you do in the leukocyte compartment. Those are mostly ideas at this point. You know, the experience in transformed follicular lymphoma is small in Florian's paper.
A question for Davide from Alexandra Travers. What about splenic marginal zone lymphoma?
Good question. Well, Alexander knows well that SMZL has a leukemic component, so all we genotype, no, for research purposes, SMZL not only on the spleen but also on the liquid part of the tumor circulating in the blood or in the bone marrow aspirates. So the question is whether there are differences with respect to what is going on in the spleen. I don't have. We didn't address this specifically. It is something that we are going to eventually address, relying on the Malibu trial, which is collecting liquid biopsies, and eventually we will have the opportunity in a subset of patients who have been splenectomized eventually, I don't know, to double check whether, but my expectation would be that as for CLL, those indolent leukemic widespread lymphomas, the difference would be limited, but this is my expectation.
I think that is a likely outcome as well. I would bet that you are correct there, Davide.
I think we can close the meeting now because there is no more question. Davide or David? One more question. We stop here. We meet at the next meeting. I don't know where.
Perhaps in person. Perhaps in person at some point.
Yeah.
Okay.
Thank you very much. I'm very happy to meet you.
Yes.
Although virtually, it's always nice to chat and have high-level discussion with, as we had now, with all the attendees. And thank you very much for the attention and for the opportunity, for giving me the opportunity to share my data and recap the David and Ash data in this exciting field of the liquid biopsy lymphoma.
Thank you very much, Davide, and thank you, David, to join the meeting and to participate all this meeting. Thank you, everybody.
Thank you.
Bye.
Bye.
Thanks so much. Bye-bye.
I don't know if...
Okay.